everyone to this seminar. I am Dr. Nicola Sarandria, and today we're going to talk about the pathophysiology and some clinical features of colorectal cancer, especially focusing on rectal cancer and touching a bit on the topic of doctor-patient interaction. So, adenocarcinoma is the most common type of a malignant cancer found when a diagnosis of colorectal cancer is made. Different type of histological origin can be found in colorectal cancer, not just a tumor from the epithelium, but there can be some GIST, gastrointestinal stromal tumors, and other tumors of a different histological origin. The adenocarcinoma is a type of carcinoma, so a malignant tumor originating from epithelium. And the fact that it is an adenocarcinoma, it means that it comes from a glandular epithelium. This type of glandular epithelium is found in exocrine organs, such as the pancreas, or in other organs, such as the colon, which contains secretive epithelial tissues. Therefore, when we talk about the adenocarcinoma of the colon or the rectum, we are talking about a cancer which has mainly three etiopathogenic pathways. The first one, which is the most common one, it is the adenoma to carcinoma pathway leading to the adenocarcinoma. This can be either due to a mutation in the germline cells in the APC gene, leading to a condition known as familial adenomatous polyposis. Otherwise, it can be due to an APC mutation sporadically, then a cascade of other genes such as KRAS, BRAF, TP53 mutations, leading to a macrosatellite stable colorectal cancer. The second pathway, it's the serrated neoplasia pathway, where the first mutations deal with BRAF, leading to either a microsatellite stable or unstable colorectal cancer. And then there is the last pathway, the rarest one, the microsatellite instability pathway. This is found in Lynch syndrome patients which have a germline mutation in the mismatch repair system genes, and this lead to a microsatellite unstable cancer. This type of cancer usually also have some peculiar features such as a higher immunogenicity. Therefore, the colorectal cancer, or better said, colon cancer and rectal cancer, because these are two conditions which are defined in this umbrella term, but would be better to be defined as two separate conditions. So colon cancer and rectal cancer, they are cancers located either in the colon or in the rectum with different actually clinical features, and together, collectively, they are the third deadliest solid tumor in the world. The majority of these cancers, they arise from pre-existing adenomas, as seen from the pathways that we described before. And these adenomas are in the form of polyps developing in the lining of the colon rectal area of the colon. There are some differences because here, when we talk to polyp formation and adenomas, we especially focus on colon cancer. Embryologically, there are differences between the colon and rectum. As we can see, there are part of the colon, especially the ascending and proximal 2/3 of the transverse colon, they originate from the midgut embryologically, while the hindgut gives the last third of the transverse colon, the descending colon, sigmoid canal, and upper anal canal. The sigmoid colon and upper anal canal. Regarding the anatomy of the rectum and colon, the colon is approximately 1.5 meters in length, and it has a columnar epithelium lining the mucosal layer. As said previously, colon and rectal cancer are two different entities, and there are differences in terms of the primary location sites of cancer regarding colorectal cancer. Here we can see in this slide some of the features. For instance, mucinous adenocarcinoma is more common in the right-sided colon cancer, while villus and typical adenocarcinoma is more common in the left-sided colon cancer. And there is a higher immune infiltrate and immunogenicity in right-sided colorectal cancer. This associated with, as previously said, a higher microsatellite instability type of cancer. The differences in terms of prognosis between colon cancer and rectal cancer is quite important, as a 5-year survival rate for localized stage colon cancer is 90%, while the one for rectal cancer is much lower, to 69%. And factors such as aspirin, low BMI, and physical activity, which have been shown to decrease the incidence for colon cancer, have not been shown to have the same effect for rectal cancer. In different countries, there are different public health policies in terms of prevention of colorectal cancer. For example, in Italy, this includes fecal occult blood testing after the age of 50 and colonoscopy once every 10 years if there are no particular risk factors present. Treatment, it involves surgery, such as robotic or laparoscopic or open surgery, and in some cases chemotherapy. There are different regimens, such as the FOLFOX or FOLFIRI regimens, which can be used as neoadjuvant or adjuvant. The difference being, one therapy is done before the surgery to cause a regression in the tumor and then do surgery. The second case is doing a chemotherapy after the surgery. Other therapies are also being used in colorectal cancer treatment, such as immunotherapy and radiotherapy. The role of the immune system is fundamental in many types of cancers, including colorectal cancers. As we know, immune cells can have a double effect in cancer. One being immune tolerance, therefore promoting tumor growth and progression, and the other one is tumoricidal effect. Here is an example of one of the chemotherapeutic agents used in chemotherapy, which is 5-fluorouracil, and causes RNA and DNA damage. The immune system and the immune cells have become so important also in terms of a clinical approach that a score has been developed where the lymphocytes within the tumor are involved in developing a prognostic score called the Immunoscore, and this is now being used in the clinics alongside the TNM staging, just to show how important Immuno-Oncology has become also in a practical clinical approach to help the patients. And it is very important that science continues to go this way, with validation, with always further advancement in science and open access science, always respecting the ethics and morality of science, because at the end of the day, as scientists and medical doctors, what we want is to preserve and help the health of the patients. That has to come first. In research and in clinical practice, there can be no other reason than the health of the patient. That is the most important thing, and as a scientist and as a medical doctor especially, we make an oath to focus always on the health of the patients. And therefore it is important that the scientific community always has all the data, all the latest informations, so that they can validate, they can make further testing, and they can understand better the pathologies in order to try and find cures or solutions to many pathologies. Here we see again the role of the immune system in cancer. In fact, the immune system can distinguish between normal healthy cells and stress cells by recognizing some kind of signals, danger signals, known as DAMPs. These can be different type of antigens, such as tumor-associated antigens, and can help the immune system in fighting these cancerous cells. And there are other type of let's say signals, which are called pathogen-associated molecular patterns, PAMPs, and these are another set of signals recognized by the immune system when there is an infection of microbes such as viruses or bacteria. Thank you for the attention, and thank you for attending this seminar.